overdose deaths last year than ever. 92,000 nationally, 67,000 opioid abuse alone.
I wouldn't say that the opioid crisis has hit Hawaii like it has on the continent, but it's definitely a concern here.
It's not a monolithic problem. It's a human problem. Addiction is very human. Self-medication is very normal now, sadly.
The perception is that overdose doesn't have a face. It affects everyone in our community.
Aloha, I'm Brooke Lee. Join me as we learn about the life-saving drug naloxone and meet the local warriors who fought tirelessly to legalize it, guardians who continue to look out for those who are the most vulnerable in our community.
Heather Lusk, Executive Director of the Hawaii Health and Harm Reduction Center, where we work to reduce harm, promote health, create wellness, and fight stigma in Hawaii and the Pacific. So the movement to have naloxone, which is an antidote to opioid overdose, into the hands of whether it's people who use drugs, the loved ones of them, basically non-trained medical providers, has been almost 30 years in the making. It started on the continent with a pioneer named Dan Bigg, who before he passed away a few years ago, distributed over 150,000 doses of naloxone. So he happened to come to Hawaii. I was able to connect with him, as were others, and he really helped us see how important it was to get a similar initiative here in Hawaii. And we just saw the incredible progress they had on the continent of people getting this into people's hands save lives. I still remember when there was 10,000 reversals reported in the early 2000s. So we then looked to the laws in Hawaii.
Community leaders like Heather Lusk, the Executive Director for Hawaii Health and Harm Reduction Center, and then Senator, now Lieutenant Governor Dr. Josh Green, led the way in 2016 to creating sustainable legislation that empowers the residents of Hawaii to take control of an overdose situation.
I floated a bill back maybe 6 or 8 years ago to decrease the prescription of opioids. And the medical community saw that and saw that policymakers were starting to move into their territory. And so then people jumped into the fray. And so we got a lot of participants, first from the private sector and the doctor community, the pharmaceutical community, the hospital community, and then the Department of Health weighed in. And so we put together a great coalition to come up with ideas. But it took a little moment where people said, oh my goodness, policymakers are taking notice of this crisis.
In 2016, the state of Hawaii decided to confront overdose prevention head-on with a new law that allowed non-medically trained persons to administer the overdose prevention drug naloxone, allowing everyday citizens the power to save hundreds of lives each year.
Act 68 was a godsend. I mean, we needed it so badly here in Hawaii. We were a little behind the curve in that, but it was a huge blessing that it finally passed. Heather Lusk, who was the executive director of the Syringe Exchange at the time, really pushed the bill a few years, and we're so lucky it finally passed.
There's still work to do, mainly because sometime in the past we saw that people's overdoses, like drug poisonings, had exceeded car crashes for causes of death, which really kind of blew all of our minds. Even as an ER physician, when I saw, the trajectory of those tragedies exceeding the tragedies from car crashes, I thought, oh my goodness, this has to be a priority.
Not everybody knows what naloxone does, and that can be difficult in providing information to everyone and also making that more readily available for people.
At this point, you're probably asking yourself, what is naloxone and how do opioids work? I know I asked myself the same questions.
Naloxone, or the brand name is Narcan, which some people know better by that name, is a medication that's administered to basically pop off the opioids on the receptors in the brain. So when we use too many opioids, whether it be heroin or a prescribed opioid, if we take too high amounts, it floods the receptors on our brain, and then it causes things like us to forget to breathe or be able to be responsive, or a lot of confusion. And Narcan has the ability ability to pop off the opioids off that receptor. So if you think of it as what we call the lock and key model, you have a lock on the brain, that's the receptor site, and the opioid binds into that receptor site. And when we administer Narcan, that actually is a stronger affinity for that lock on the brain, that receptor site. So it's able to pop off that opioid and replace that receptor site with something safer, which is the naloxone. So Narcan truly is a game changer for us. It's been a life-saving medication.
Naloxone is a drug, and it is a prescribed drug approved by the FDA. It has no consequences if you're not on opioids. We're having naloxone as one of many tools that are available both to our first responders, our pharmacists can now prescribe it. It's getting into the hands of people struggling with substance use disorder, or even our kapuna who have a high rate of overdose.
That's why having naloxone still is actually, in a lot of ways, a better tool, because it's something you can do right there. You can save that person's life right there.
You can save a life. First, you need to check for signs of overdose. Limp body, pale, clammy face, blue lips or nails, vomiting or gurgling sounds, inability to speak or be aroused, slow breathing or heartbeat. If you see any of these symptoms, first call 911. And then administer naloxone. How does one do this? One option is with a nasal spray given while the person is on their back. Another option is to inject directly into the thigh muscle. Sometimes more than one dose is needed.
I'm Paige Nakamura, and I work with the Syringe Exchange Program at Hawaii Health and Harm Reduction Center, also known as H3RC. I've had a half a dozen overdoses around the area while I was working in the van that I've had to go and administer Narcan. It's a really good feeling, to bring somebody back. This is the injectable one, and this is the nasal one. They work exactly the same. It's really just a matter of personal preference. And it only works on opioid drugs. So if they're using any other drugs or they're drinking alcohol, it's not going to affect that or counteract that or mix, wrong with it.
ADAT has a contract with HHRC to provide substance abuse related services in the community, things like naloxone distribution. We've actually identified substance use disorders as a disease for a couple of centuries now, as far back as the 1700s, but we still haven't gotten over the stigma related to substance use disorders. And we're gonna have to really move the needle on that if we're gonna do anything.
It is because of the stigma that many die in silence from overdoses, never feeling that they can get the treatment needed to deal with their situation. This is where a therapeutic model known as harm reduction comes into play. So what is harm reduction?
I think the difference between harm reduction and traditional rehab or drug treatment is centered around abstinence. And abstinence doesn't work for a lot of people. And I think that harm reduction is a much more realistic and humane way of going about it. Meeting people where they're at. We have low barriers to no barriers for assisting people and getting them the supports and medically assisted treatments that they might need.
We do that both literally and figuratively. So literally is we take naloxone out into the streets and meet people and distribute that way. More recently, we're doing naloxone trainings over Zoom and then sending naloxone in the mail to service providers and others that may need that. So meaning we take our services to where people are, make them easy to access, things like that. But we also need to figuratively meet people where they are, meaning if somebody's not ready, willing, or able to talk about substance use treatment, then what else can we talk about to help them stay well and healthy until they may be ready to talk about that? Another example of that is that relapse is one of the indications or one of the reasons why people may overdose. Plus, maybe you're hiding it because you have shame, you didn't want to tell anybody you relapsed. Unfortunately, that's a recipe for overdose. So again, it's how do we create that come as you are, and we're going to celebrate your victories and help you get there, but we're also not going to abandon you.
At H3RC, we embody the harm reduction principles, and one principle is to meet someone where they are. And what that kind of means is not just literally meeting people where they are, which we do. We go into the community and meet patients right where they might be living or right where they might work or stay primarily, but also meeting patients where they are in their readiness for change. But we always remember we have to go at the patient's pace. And so that's talking to people about what their goal is, and it might not be a long-term goal. It might just be, what are you doing in the next hour, and how can we help keep you safe, and what needs can we meet today in this moment? And I think that is really sustainable.
Some of the most vulnerable on our islands are our kupuna and Native Hawaiian populations.
You don't know who uses, who doesn't use, who has used, who may use. It's not something obvious, and it can affect anybody.
So when we look at high rates of drug use in our Native Hawaiian community, we have to look at things like historical trauma. We have to look at things like oppression, racism, colonialism, things that we have faced that affect us to this day. So what are the drugs doing for people that other things are not? If I'm houseless and I sleep outside in the park and I'm a single woman, and I get attacked at night, I'm going to use meth, I'm going to use ice to stay awake, and that's a tool for me to use.
We have about 24 to 26% of the folks that access the statewide syringe exchange identify as Native Hawaiian. So that's about a quarter of them. And why not all of those may have the opioid be their drug of choice, that's very disproportionate compared to when you look at that across the population. Homelessness is a factor, as we know here in the islands, is a really big issue. The national data says that people who experience an opioid-related overdose are 10 times more likely to die if they're houseless.
I think that with expanded education will come more understanding. It'll foster more empathy, and people will realize that the people who use drugs, who do injection drugs, are not just people who are committing crimes and dirty and homeless. This kind of stereotype we have of a heroin addict.
One of the reasons that opioid overdose is an issue in our Kupuna community is capitalism. A lot of people are left alone when they shouldn't be. We have a lot of older folks who have chronic pain issues and have very real reasons to be taking opioids for pain relief. In Hawaii, our rents are so high, our mortgages are so high, even if we live in a multi-generational home, we are beholden to work. A lot of us make minimum wage, even if every adult in the home is working, so no one can stay home with our elders to take care of them and watch them. Sometimes we have things like pill separators that are a tool people can use to make sure if they're not home, you're taking your pills at the right time. Those things aren't always foolproof, and so people get left alone because there's not enough caregivers.
When we look at who's impacted by opioid-related overdoses in Hawaii, it's not like the continent. So first of all, again, overall, people use more ice than opioids, but even within the overdose data, we on the continent often see younger people. Here in Hawaii, we actually see more of our kupuna, 45 to 65. So we also, in addition to people that we may think about being an opioid user or someone who injects heroin, we also have people who have legitimate pain prescriptions for their medications, and those can also be, if taken too much or accidentally, could lead to an overdose. So we're also trying to really target our kupuna and folks that have chronic pain medications to make sure they can get naloxone.
Anyone that's been prescribed opioids really needs to have Narcan or naloxone available to them. If we're prescribing opioids, whether it's an appropriate situation, then we still need to think about the safety of those medications and the risks that opioids present to patients.
This is an important thing that I really think that everybody should have a naloxone kit on hand. Every state worker should have them. I think all police officers should have them. The school nurse should have it. And definitely when you go to the pharmacy and get some pain medication, that the pharmacist should give it to you.
For the last 15 years, the spotlight has been on pharmaceutical companies and their role in the development of the opioid crisis in the U.S. Purdue Pharmaceuticals, manufacturer of OxyContin, pleaded guilty in November of 2020 to 3 felony offenses related to the opioid epidemic.
These funds will be delivered to the communities where the help is most needed. These grants will also support state and local governments in obtaining high-quality, comprehensive data so that we can help the most people and save the most lives.
That can mean everything from expanding the use of medication-assisted treatment in criminal justice settings or in rural areas via telemedicine.
I think the couple things that come up for me is one, Hawaii is one of the states that is going to be getting some opioid settlement dollars, so that's going to support our treatment continuum and our prevention efforts. I think another really important area, there's a better dialogue about pain management than I've ever seen in my 50 years on this planet.
There's no way we will ever truly be able to hold them accountable for the damage that they've done and the lives that have been lost, all the people who have died because of them withholding information about how seriously addictive prescription opioids are. And so we have to kind of balance that. We need to have pharmaceutical opioid pain relievers to exist, but also we can, hold these corporations accountable and understand that they don't actually care about us and they care about profit.
Well, I remember when I was in medical school back in 1997. And then they told us pain is another vital sign. Never let anyone have one moment of pain, and narcotic medications are not addictive. They told us 1% of people will get addicted who get put on heavy doses of narcotic pain pills. It had a devastating effect on society. So that misinformation means that they have to be held to account, and their money, their profits from pharmaceutical sales all across the globe needs to be spent on basically penance. They have to provide service, provide care, cover the cost of recovery, cover the cost of any therapy that's necessary to bring people back to life. The next wave of making this a primary healthcare problem, to treat people after they're suffering, that resource and money should come from the settlements and basically the lawsuits that they are guilty of hurting people.
As the opioid epidemic spirals on the mainland, Hawaii has been able to harness the power of local community action. From legislation that created the Good Samaritan Law in 2015 and Act 68 in 2016, to agencies like H3RC and the Hawaii Opioid Initiative providing free naloxone and usage education for the public and medical professionals.
The stakeholders and other folks who are involved in addressing substance abuse in the community, HIDA, HHRC, many others, we really got to continue to come together and address this issue collectively and in a more unified approach. If we don't, then we just end up wasting resources on what we're trying to actually accomplish.
Government agencies work with local nonprofits to stem the tide of the opioid epidemic by really providing support. The government agencies can't do everything, so we really rely on other nonprofits and community partners to provide prevention, recovery, and treatment options and different resources for our community.
This is a primary care healthcare problem. It's not a specialty problem. It's not a problem that is kind of abstract. It's very real. And so Suboxone is a real solution. Overdose prevention is a real solution.
In terms of overdose prevention to evolve, we have to evolve to be honest about what causes drug use, and also how we combat overdose from like an unsafe drug supply. So if we are truly serious about ending overdose, we have to look at the material conditions that people live in. So what would help end overdose? Healthcare, having housing, having jobs that pay a living wage, people having access to their own land, people feeling a sense of community. If we work on these things, that will help overdose prevention. But in terms of drug use that is already happening, we need access to a safer drug supply. We need more robust systems for testing drug supplies. We need safer use facilities where people can go to use safely and legally. And we need to decriminalize all drugs. The stigma is what kills people.
We begin with the number of drug overdoses climbing, reaching a 5-year high in 2020, nearly all of them accidental.
This comes as an extremely dangerous opioid continues to make its way across the nation, including here in the islands. Sam Spangler explains in the story that's new at 10.
The drug is called fentanyl. The CDC says deaths linked to it were up 55% last year in America. And it doesn't take much to kill. Just a few grains of sand worth or a milligram are lethal to almost anybody.
Ice is the drug of choice in Hawaii. We need all people who use drugs and people around people who use drugs to recognize the signs of opioid overdose, though, even if ice is their drug of choice. And that's because at this time, fentanyl has been found in our drug supply. You add a little bit, it's super strong, it makes people think their drugs are better. So even if someone's drug of choice is ice, they are still at risk of an opioid overdose because they might unknowingly have taken ice that was that had fentanyl in it.
We give out test strips so people can test their drugs. Doesn't tell them how much there is, but it tells them that that's in there so they can make a more educated decision on how much they're going to use or do a test. And we've had people who have overdosed and died from the fentanyl in the methamphetamine because, they're opioid naive, they have no tolerance.
We call substance use disorders a disease, and yet we oftentimes don't treat it as such. And if we're really going to move the needle on substance use disorders, we're going to have to start treating this like we would any other disease, like diabetes or heart conditions.
We're working for Hawaii. This is the KHON2 News at 5 with Howard Deshefsky and Bridget Namata.
Like many of you at home, we woke up to some very sad news today.
Colt Brennan, who brought so much joy and happiness to Hawaii football fans, dead at the young age of 37. According to the University of Hawaii Athletics Department, Brennan died early this morning in California.
The Costa Mesa Police Department confirming to KHON2 he was taken to the hospital for a drug overdose. Brennan's family released a statement saying he passed away peacefully with his sisters, mom and dad by his side, listening to Bob Marley with a lei on his chest. He loved Hawaii, and we are forever grateful.
The stigma of overdose and substance abuse prevention inhibit many from seeking help. People we know struggle in silence without the help of family and friends.
Some things we don't know. People have been so isolated for the last year and a half, it's been hard to communicate their crises. But we do know they've been calling for help. We do know that addiction has been up. We do know that people self-medicate when they can't see their primary care provider or their specialist. And that probably means a lot more addiction. A lot of people have suffered during the pandemic, so as we come out of it, we have to be ready with our social workers, our psychologists, our psychiatrists, our primary care doctors, and a lot of people are going to have to recover that part of their life because I think there's been a lot of suffering behind closed doors.
For a long time, Hawaii's opioid problem has taken the form of prescribed opioids. From our best information, we think victims had legal access or prescribed access. Our peak for all opioid-related deaths was probably around 2010 or 2011. And since then, we've either plateaued or slightly decreased up through 2020. But what's changed within that overall picture is proportionally fewer deaths due to the commonly prescribed opioids and more deaths due to the probably illicitly obtained opioids. We've seen prescribed opioid prescriptions decrease by about 30% since 2015. But we've seen a steady decrease as doctors want to avoid prescribing these substances altogether out of care for the patient and these concerns. So we really, I don't think, have the proper data to make those connections.
But there were a lot of people who were on long-term pain management drugs that have major chronic pain issues. They've been subsequently cut off of their pain meds, and so they've ended up turning to street drugs. People are going to be doing drugs. They've been doing drugs, and that will continue, no matter how we criminalize it, how the laws are written, how much stigma there is.
To this day, I still face stigma. It's kind of hard to go walk around without a shirt because of the scars on my arms and stuff. But I just remember that I'm getting better slowly. So, yeah, I just got to remember that. So.
Personally, I'm actually myself in recovery from injection heroin use, and I personally saw somebody overdose and almost die. And from that's when I first heard about naloxone.
If I wanted to talk about really putting serious effort into recovery, like going to treatment and doing that route, 3 times. The first time I made it to 20 months, and then my fiance passed away, and that took me right out. The second time, I had a year, and I relapsed because I was cut off from supervision. I wanted to do what I wanted to do. And then now this time, I have now been off of drugs and all substances since February 6, 2012. So that's 9.5 years. I did it for myself. That's what made it stick. The previous times that I tried, I don't think I was doing it for the right reasons. And I had a distraction for me of being in a relationship with somebody who also was struggling with their own addiction. I also think that it was just also, I had been kicked around enough, and I had kicked myself around enough that I didn't want to do it anymore. I didn't want to die, and I was gonna die sooner rather than later. I wanted to become part of the solution rather than part of the problem.
All of our work on data and epidemics in general have been the COVID epidemic. So the epidemic of drug abuse and overdose, I wouldn't say has been on the back burner, but we haven't been able to focus nearly as much resource in this last year and a half. So I think what we're gonna do is we're gonna emerge from the COVID crisis, and we're gonna peel back that layer of our challenge, and we're gonna see all of these challenges that still exist. The self-harm, the increases in addiction, the amount of depression that's gone on, and the self-medication that goes with it. I think we're gonna find a lot of data that unfortunately breaks our hearts a little bit. And then when people get back to work and they get back to their lives, they get to see their families again, all that should recede.
Hey, saving lives, that's what it's all about. Narcan, do yourself a favor. If you do injection drugs, come down to the van and get yourself one of these kits. It'll save someone's life, like I just did right now. Thanks. We're Hawaii Health and Harm Reduction Center, and this is what we're here for. Mahalo.
Please contact Hawaii Health and Harm Reduction Center at www.hhhrc.org for more information on naloxone training and access.